Minimize noise interference and maintaining streaming quality during the session, we have muted your mic and turned off your cameras. We would like to encourage conversations though, and would like everybody to use the chat box. As the chat box can get very busy, one tip to allow you to directly reply to a comment is to use the reply function. Use the emojis and reply function for communicating with others in the chat box as well. There is also an option to turn on closed captions on your end. Select the dots for more options, the three dots, and then turn on live captions. You'll receive a notification showing your set language. Live captions will then be shown towards the bottom of the call screen and will only be visible to you. Specific instructions to turn on is in the chat box. If you're experiencing any technical issues, please let us know in the chat box so we can help resolve it. This webinar is recorded and published on our webpage. A link will be shared so that those who are not able to join us today can listen to the session. The chat box is not recorded. The purpose of our webinars have remained consistent since 2020. They are a platform where we can explore what changes we have made and what we need to make as we move forward. It is also a space to connect and learn from each other. This webinar will be split into two sessions and they will be led by Michelle Ward, Senior Medical Advisor in the Scottish Government, and Scott Jamieson, Clinical Director in Angus HSCP, GP in NHS Tayside, and RCP Scottish Council member. In session 1, we have speakers talking about the national perspective on respiratory care and management in primary care. And in session 2, we have speakers speaking about examples of respiratory care and MDT management in primary care. As we only have 1 hour today, we will be highlighting a very small sample of the topic of respiratory care and management. Without further ado, I'm going to hand over session 1 to Michelle Watts, who's our facilitator. Michelle, over to you.
Brilliant. Thank you very much, Adeline, and welcome everybody. It's great to see so many people from all four corners of the country, and thank you for taking time out of your busy working weeks to join today's webinar. I hope you'll find it useful, educational, and above all, an opportunity for making some connections and sharing some learning. I think this is a good time to have a respiratory webinar. You were coming into winter. I'm sitting with my blanket around my knees today because it's so blooming cold. And alongside that, as you know, comes the inevitable increase in the pressure on services. And already health boards are starting to put out the inevitable messages about bed spaces and increased pressures and everything else. So again, really good timing for today's webinar. I think the other thing to recognise as well is we're all beginning to see as we start to get out and about and prepare for Christmas, all the circulating colds and coughs and sniffles and adding a fair amount of COVID alongside all of that. I think certainly this winter is going to be as bad as it ever is in all the winters we've had over the previous years. And for any practices who don't do it or are considering it, really encourage you to think about becoming a spotter practice for Public Health Scotland, and using that surveillance data that we pick up every week can be incredibly helpful to tell us what organisms are circulating around in the community and how we can get that feedback back to practices as well to really help clinicians at the front line understand what's driving some of the respiratory cases over the winter months as well. Alongside that, as you know, in all of our areas, we're working to do more to bring respiratory care into communities and bring care more close to home. And the way that we do that is through really expanding that multidisciplinary team approach. And today we've got some fantastic speakers outlining just a small amount of the work that's happening across Scotland, from a specialist viewpoint right through to the importance of actually looking after yourself and how you can do that with a bit of joy as well. And I'm really looking forward to hearing Anne speak later on today. So without further ado, I'm keen that we move on and introduce our first couple of speakers. So today we've got Dave Anderson, who's a kind of consultant respiratory lead in Greater Glasgow and Clyde, and also our national clinical lead for respiratory, and Alton the Mayor, who also heads up our quality prescribing and therapeutics division, and both of whom have been instrumental in helping to produce some really comprehensive work around respiratory prescribing and guidance that's about to be published is out for consultation at the moment. And as part of that, Dave and Alpin and the team, particularly led by some of our pharmacy colleagues, Emily Kennedy in particular, have produced a fantastic toolkit, really practical, really pragmatic, simple approach to help clinicians in everyday practice. And we'll post some links to that in the chat bar today, and look out for it in a practice near you in the next few days. So before I introduce Dave, first of all, the chat bar, keep it going. Every webinar, it's usually dancing like a circus. So please, pass any questions, comments, queries, anything you like, and hopefully we'll have a bit of time to pick some of them up at the end. But without further ado, I see Dave's lovely face on the screen. So welcome, Dave, and over to you.
Thanks very much, Michelle. And just reflecting as I'm doing the ward round today, there's can you hear me okay? Can people hear okay?
Yep, all good.
Yeah, I'll just say just doing the ward round today and just reflecting in the everything that you did, Michelle, during the pandemic as well. And I don't know if that's been acknowledged as much as you did, but all that work you did at the start to get the primary care response up and running, which made a huge difference in secondary care. So I think it's important we acknowledge that. Grant, can I get the next slide, Adeline, if that's possible? Right. So can you just kind of click down the slide, because there's a few wee bit of a graphic in there. So I've got 7 minutes to talk about COPD and what we can do to help with COPD in the community, and how we can expand it on to help with other conditions as well. So this is a traditional trajectory of COPD, that someone starts having symptoms maybe 10 years from death, and it's a progressive condition. They get recurrent exacerbations, and gradually things decline and they reach end of life. And there are so many things that we can do to help patients to prolong life, to improve quality of life, and to improve patients' standard of care. And I've just highlighted some of those things there that we can do, ensuring we diagnose early, ensuring we stop smoking. Exacerbations have such a huge impact on quality of life. So if someone's got an exacerbation, then managing that appropriately, identifying what patients need oxygen and how oxygen can help in those circumstances. And then there's the mainstay of management of COPD is pulmonary rehabilitation, which includes education as well as strengthening muscles, strengthening cardiac response to exercise. And that's the one thing in COPD that will prolong life if patients can effectively complete it. Identifying what patients need other input, like financial support, dietetic input, managing anxiety and depression. But as patients progress and we've done all those mainstay things, what else can we offer? And we'll talk a bit about community respiratory teams and how they can help. Other more niche things, which are secondary care based, include lung volume reduction surgery and transplantation, and we want to identify appropriate patients for that. And then finally, domiciliary non-invasive ventilation for those patients who are needing ventilator support at home, which has been a huge impact on mortality and readmissions. Could I get the next slide, please? Thanks. So I'll always show this slide when we're speaking about COPD, just to recognise that it's a disease of deprivation. It's not just smoking, there are other factors going on. So this slide shows the prevalence of COPD per 100,000 in all the 22 GP clusters in Glasgow City. And then taking that GP cluster and showing what percentage of patients in that cluster are from the lowest 20% quintile. Someone said slide's not changing.
It is moving for me.
Yeah,
yeah, if it's not changing, I'm sorry to interrupt the presentation, David. You might have to leave and then come back again.
Yeah, okay, thank you. They seem to be slightly moving okay. So then we could come back to this graph. The graph is in the y-axis what percentage of patients come from the lowest 20% denominator, and you can see a huge correlation between the two. And you know, if you come from the most deprived area, you're much more likely to have COPD than if you're from the least deprived area. And it's actually a sevenfold difference in Glasgow and Clyde between the highest and lowest demographic. Can I get the next slide, please, Adley? So there's only so much that we can do in secondary care. You know, there's 120,000 patients with COPD in secondary care, and 120,000 patients with COPD in Scotland, and we can't see them all in secondary care. So we need to be imaginative about how we can support these patients. And so we've got our community respiratory teams, which are established in a lot of areas in Scotland. And the idea for that population is to offer them a holistic support that's slightly more than pulmonary rehab can offer. And so trying to work out if these patients need specialist physio input at home. Often these patients will be unable to attend for pulmonary rehab, so they require more intensive domiciliary input. Also looking at nursing input, thinking about palliation of symptoms, ACP discussions and breathing control, as well as making sure that appropriate nebulizer use and inhaler use. And dietetic and pharmacy reviews crucial as well for the appropriate patients to make sure they're utilising the medications appropriately. And then occupational therapy to ensure patients have the right equipment at home and they can manage to cope with their breathlessness more. Can I have the next slide, please? So just looking at our evaluation of community teams in GG&C, and this is Glasgow City. Pre-COVID pandemic, we managed 1,000 patients per year. We've shown that it improves our quality of life. We show that we have a significant impact on hospital admission. And if you look at hospital admission alone, then it saves money. So it's a money-saving tool, even when you take the cost of the team into account. But it also has a significant impact on admission rates and significant impact on quality of life. So it's a financially negative team, but also has positive impact on admissions and quality of life. Could I have next slide, please? And I'm just going to briefly mention what we might be able to do in the future. As an example of during the COVID pandemic, we amalgamated our existing services, including our nurse specialists, community respiratory teams, physios, pulmonary rehab teams, and put them all together to provide a community response team for the whole of GG&C. We covered 1.2 million population for all chronic diseases. And to do that, we suspended all routine work. And if we can have next slide, please. And what we found was we're able to offer so many more appointments, and this is a period between March and September, so that'll be a 6-month period. We're able to take 2,600 referrals in a 6-month period and offer 10,000 consults in the community for this population group. That's taking pressure off secondary care, taking pressure off GPs and other primary care practitioners, and offering patients a good and a alternative to either hospital admission or constantly having to see the primary care provider. Next slide, please. And when we looked at the impact of that process on hospital admissions, so this is the graphs for admissions in 2018, 2019 and 2020, and this is other health boards in Scotland but not in Greater Glasgow and Clyde. We did see a drop-off at the start of the pandemic, but at the time you got to September in 2020, you saw the lines coming up to near normal levels. So hospital admissions came back up to normal levels. And then next slide. But when we looked at it in Greater Glasgow and Clyde in 2020, we were able to maintain that and we were able to reduce admissions in a pronged basis, not just at the start of the pandemic, but throughout the first year of the pandemic. Unfortunately, after that, because we had to restart routine services, which were vital to our respiratory patients, then we had to suspend this process and go back to the provision only being for Glasgow City and only being for COPD. So next slide, please. We're trying to find other imaginative ways to support patients in the community, and we're using tech. This is what was initially called the dynamic SCOT pathway, and that allows patients to have smartphones and to monitor symptoms in the community, as well as monitoring their activity levels and to try and identify exacerbations early, identify those patients at high risk of mortality and offering interventions to try and prevent that. So patients might get a phone call saying, you're about to exacerbate, please make sure you've got antibiotics and steroids at home, and then hope is with this tech that we can maybe intervene before the patients are aware of it. Next slide. And so just 2 quick slides. Current process, COPD exacerbation, contact a team, you get admitted, you get discharged, you just go around in a cycle. So if we can provide instead a community spread team response, manage the patient at home in appropriate fashion, rehab them early, and then hopefully that breaks the cycle of recurrent admissions. And if we just keep going round, Adeline, hopefully that's, see, you'll get them into a formal rehab programme, and that prolongs period to next exacerbation, identifying patients who might need intensive care planning, identify patients who might want to see in secondary care clinic, and using the digital pathway for this. And then just finally, we should have where we can offer ventilatory support, ambulatory heart failure services, acute failure service and hospital home, and we build in and work with all patients. And then just final slide, if that's okay, then, you know, this service does work. We've got evaluations that show it works. We need to provide equity of service across Scotland. It's currently available in many health boards, but not all health boards. Ideally, we want it to cover other conditions other than COPD. We want to interact with hospital home programmes, we want to interact with frailty programmes, we want to interact with OPAT services as well, and then interact with out of hours, emergency departments, acute medicine departments as well, and trying to bring it all together, so offering a holistic care, not just for a patient who's got COPD, but patients who've got a lot of chronic diseases that we can manage in the community. And hopefully that's all my slides. Is that right?
Yeah. Fantastic. Thank you so much, Dave. Lots of questions starting to emerge in the chat bar and loads there. And I'm still reeling over your COPD slide in Glasgow and the difference between deprivation and non. What a startling statistic that. Lots of claps, quite rightly deserved. So I'm going to hand over without further ado to Alpna and to continue telling the story and the work that's been happening around developing a quality respiratory guide as well. So over to you, Alpna.
Yeah, no, thanks, Michelle, and thanks to the team. So several members are on the line just now, but Dave and Tom have chaired this work, and Leslie, Rose, Emily and Karen with Ian have helped lead this. So I have the pleasure of sharing the key points of the quality prescribing guide with you. So next slide, please. So this guide has been formed together with people with lived experience, looking at 4 key areas, taking a person-centred approach. So COPD, asthma, interstitial lung disease and bronchiectasis. And the aim of the guide is to have improved patient outcomes by undertaking person-centred medication reviews using 7 steps that you can see on the right-hand side. And by taking that person-centred approach, we're aiming to optimise disease control, to involve shared decision-making and to reduce the hospitalisations. What we want to do is to give people better quality of life, reduce the outcomes, to improve the outcomes by reducing the reliance on short-acting reliever inhalers. And one of the things that we do have to think about, we start with what matters to the individual, making sure that we have the right treatment for the individual. And when we're making sure of that, we need to make sure that the treatments are effective. So making sure that people do have preventative treatment as well as relievers that they may use. And we need to make sure that we use a most environmentally and sustainable option as well. So this is about having that shared decision-making conversation with the individual about the best inhaler that's suitable for them. And we do need to therefore think about the advice that we may give an individual to agree with them on the best and safe disposal of the inhalers to make sure that any materials that are left within the inhaler are appropriately recycled and destroyed. So next slide, please. So the guide focuses on 4 key areas that I'm sure that you'll all be familiar with: the diagnosis, the right drug, the right device, and the right disposal. And by doing that, it's about getting better care for the individual, and that should also mean better respiratory care and greener care for the environment as well. So it's done with that in mind. So rather than starting with what's the most environmentally friendly inhaler, it's really focused around the individuals, their symptom control, and improving their outcomes. Next slide, please. So we know that approximately 9% of admissions to hospital each year are due to asthma-related deaths. And this is known from the studies due to excessive use of the short-acting inhalers. So we want to make sure that we improve a patient's day-to-day symptoms by making sure that they're on the right preventative treatment, and so they have less of an over-reliance on the short-acting rescue treatment. Whilst we're addressing the actual device and the effect that this has on the environment, we also know that actually having to go to hospital, taking into consideration the admission, the stay and the visits, also has a carbon footprint. So we need to think about that as well. And it's estimated about 500 kilograms of carbon emissions due to one emission from a asthma exacerbation. So we need to think about that as well as the actual device itself. So next slide, please. So one of the ways that we are doing this in the spirit of quality improvement is using data to help us drive that change. And so there are national therapeutic indicators that you can access, and we'll put the link on the side. And the recommendation is to make sure that we prioritise people that are using 12 or more SABA inhalers, with the aim to get this down to 3 SABA inhalers a year. We know that there needs to be acceptance that for some people there may be a variation in the number, but these targets were agreed with people with lived experience to agree a target that most people would be able to achieve. The SABA inhalers drive about 70% of the greenhouse gas emissions from inhaler devices in the UK. And that's why there's a particular focus on them. But more importantly, we know that from the national reports on asthma deaths, that those people that tend to use excessive rescue treatment tend to be those that are associated with poorer outcomes and increased risk of exacerbation, so and hospital admissions and deaths. So there's our driver. Next slide, please. And this is just an illustration that we can use that's in the guide to try and help explain to patients the difference changing from one device can make, and also for us to understand as healthcare professionals about the difference in the carbon footprint of the different inhaler types. We often get queries about what if patients can't use the dry powder ones. There are studies that show that most people can manage, and there are devices as well that are available, like the InCheck device that can be used so that people can feel confident to use the dry powder inhalers and make sure that they've got enough inspiratory flow. Next slide, please. Quite often there is concern amongst both the patient community and other clinicians about the drivers around reducing and changing to a dry powder inhaler. And we need to be reassured that changing to a dry powder inhaler doesn't have a detrimental effect on asthma deaths. So if we are one of the highest users of metered dose inhalers with the propellant, and our asthma death rates are quite high as well. If we look at a country like Sweden, though, you can see how low the metered dose inhaler is used in Sweden, and they also have a very low rate of asthma deaths. So we can see that there's clear evidence there's not association that dry powder would result in higher asthma rates. So by taking that person-centered approach and having that discussion with the individual patients, making sure that they can use the device will ensure the most appropriate outcomes for that individual as well. Next slide, please. So what we are hoping to supplement the national therapeutic indicators with is really a whole system dashboard. So we know that there are many factors, and Dave's also already alluded to factors around deprivation. So to have a dashboard that has asthma admissions, for example, asthma prevalence, deprivation, and alongside that to look at all the national therapeutic indicators that are linked with respiratory on one slide, together with a map of CO2 emissions or pollution, so that we can see where pockets of high pollution might be, and this will help drive a whole system approach in terms of addressing respiratory prescribing, so that making sure that more appropriate management, better use of preventative treatment will have a positive outcome on reducing the asthma admissions. So this is in development just now, but the aim is to have this available. Next slide, please. And so by focusing on reviewing the medications will get the best outcomes for individual, but will also avoid the environmental impact. And we know that 1 in 10 medicines prescribed in Scotland each year are incinerators, and you can see the carbon footprint of all of that has each year in terms of the number of journeys around the world. So it's really important that people do return their inhalers for safe disposal. You know, where the gases are trapped, they can be effectively extracted and dealt with appropriately. So encouraging people to return inhalers back to the pharmacy is really important. The other important aspect that I'm sure many of you will be aware, but just worth pointing out to patients, is that often the dry powder devices also have a dosage indicator that helps people know how many dosages are left. So next slide, please. So there will be a respiratory toolkits available to help manage asthma together with the Managed Medicines app. And these are the key steps that are outlined, and Emily's put the link up to the app. So please, and to the toolkit. So please take time to have a look at the toolkit, taking through the main steps with the information on how to prioritise patients and access the key tools. So next slide, please. And this is really just pointing out the respiratory content on the Managed Medicines app, and you can access this through the QR codes here, but it breaks it down into the 4 key areas, but also the key steps to go through with patients. And there'll be some information for the patients as well that's developed that will also be on the patient side of the app. So next slide, please. So there is, as I said, a consultation out at the moment. It closes at midnight today. So please do have a look at the consultation, where the respiratory guide is available both on the app and online for you to have a look and comment on. And I'll hand back to you. So thank you everyone for listening.
Brilliant, Alpna, thank you. So what I think we're hearing from both our speakers there, that good person-centred shared decision-making, care planning, careful consideration of prescribing and non-prescribing matters, working as part of an MDT to support early intervention for people with respiratory conditions, reduces exacerbations, reduces hospital admissions, improves team working and value-based prescribing. And by the way, we get a greener and cleaner environment as a consequence. What's not to like? Just before we hand over to our next set of speakers, a question for Alpna and Dave really quickly. What one piece of advice would you give to primary care teams this winter around respiratory? Dave?
Oh, for God's sake. Just one.
Just one.
Oh, that's difficult. I just put in the chat, this is a totally random thing. Can I give 2 pieces of advice? I just put in the chat, if we're struggling to diagnose, if you hear crackles, you've got to think about not being COPD, because we know spirometry is miles behind. So if you're hearing crackles, think about ILD, think about bronchiectasis. Those patients need a scan. The second bit of advice is, I'm really keen to keep primary and secondary care talking individually as well as in sessions like this too. So trying to keep in contact with your local physicians and secondary care physicians and trying to engage in conversations. I love getting emails from my GP colleagues who I've worked with before and who are my friends, and it's nice to have a bit of back and forth about these things. So not just putting referrals into the system, you know, dropping us an email, asking if phone calls are sometimes difficult because we're all busy, but trying to keep that communication. We're all on the same side, we're all working in the same direction, and we need to keep talking. So that's my, off the top of my head, that's my bit of advice.
Fantastic, really good advice, and very welcome to Alpina.
Yeah, as Dave says, this is a really difficult one. There's so many things, but I guess maybe prioritising your patients who are on 12 or more SABAs, particularly as we get to before winter, and using the wider MDT to get involved here and to ask them, you know, what is it that they're struggling with, and just to have that open conversation with them.
Brilliant, thank you so much. So some really practical hints and tips, and if in doubt, pick up the phone. Not clear about the diagnosis, consider alternatives and get some help from your friendly pharmacy respiratory team, and be great to see it. Be great to come back next year and see every area talking about what their community respiratory teams are up to, because we've got to do more of this and push for it. Brilliant, thank you so much. Please do keep the chat bar going, and I'm going to hand over to Scott.
Thanks, Michelle. Guys, that was really good first half, and it's great to see we're bang on time. So hopefully we can keep it on track. So Scott Jameson, GP up in Tayside, and the Associate Clinical Director within Angus, and here with my RCGP hat on. RCGP continues to be really pleased to support this, and we've got two really good speakers in the staff. First of all, we're going to hear from Claire, who's going to talk to us from her Midlothian perspective, where they've been looking at community rehab. Community respiratory teams and sorry, not community rehab, community respiratory, and looking at all the great work that they've been doing, all the different things that we as clinicians, I suppose as GPs, we take for granted a little bit and just say, oh, they see what they can do, and these are amazing things that the community respiratory teams to improve COPD, reduce exacerbations, and improve symptom control for a disease, as we know, that does not have great treatments at all, certainly from a medicines perspective. And then hear from Anne Ritchie, Anne, who was the founder, as I recall, co-founder of the co-founder of the Chain Gang, and talks to us about the benefits of some of the wider approaches to respiratory health and how to improve respiratory conditions, especially during winter times. We really look forward to hearing about a completely different way to approach this. I think if you guys hand one over to the other, so just moving straight from Claire on to Anne when you're finished, I really look forward to it. Please keep going in the chat, guys, and keep questions up, and people will continue to pick off answers as we get them. Claire, are you ready to go? And we're looking forward to hear from you.
Yes, thank you very much, Scott, and thank you to Adeline for asking me to come and speak to you all today. Can you hear me, see me? I can't see my video, so I'm hoping
we can hear you,
okay.
but we can't see you. But we'll try and fix that in the background. But we can definitely hear you if you want to start.
No worries. So yeah, my name's Claire Yaramasi. I'm the team lead for Midlothian Community Respiratory Team and Advanced Physio Practitioner. Next slide, please. And next slide. So Midlothian CRT, we're made up of physiotherapists, a dietitian, clinical psychologist, and we've just had a nurse seconded into the team for a year review. One of the things in this slide is to just highlight the system linkages column there. So we've got a prof to prof line into the medical team, and that's just a phone line into the medical team in the Royal, and that's to help us with really complex decision making for the community patients that we see. Also, we do a 2-weekly MDT with a respiratory consultant, which again helps with case reviews. Our COPD, our work streams are COPD, and we've got a CRT plus facilitated discharge work stream as well, and that is for a short amount of time following a hospital admission. Next slide, please. So this slide,
Claire, can you try and pop your camera on? I don't know, we can't do it our side. You okay to pop it on your side yourself? Thanks so much.
Let me try switch camera.
It's okay if not. It was working earlier. I saw you before.
Yeah, okay, let me.
Don't worry if you can't get camera. Don't worry, just keep going. It's fine. Don't worry.
Sorry about that. Oh, camera, right? Let's see if this works. Turn on your camera. Just do one more thing. Get rid of that one. Can you still hear me?
Yeah, we can still hear you. Just keep going. It's not a problem. Thanks so much.
Sorry,
Yeah, we've got
sorry.
you. Don't worry. Keep going. Keep going.
Okay, no go. Sorry about that. Yeah. So this slide just really tells us what we thought about when we were setting up the team initially, and on to a little bit about the data setup. So we thought about who would help us initially setting up the team within the partnership. What do we need in terms of staffing and technical support for the team in order to create a really sustainable team with a data focus, and that we were going to be able to demonstrate benefits for a senior management team and that sort of thing. So in the beginning, it was really important to collaborate, to have a stakeholder group that included the consultant, GP, clinicians, project management, and other managers to really help us set up a team with an aim, and then to think about later on having a digital lead and digital analysts involved in the collecting of data. That was a really key thing to be able to demonstrate and then grow the team. And in with that, there's the change management and the creativity that we had, which, you know, was developing constant cycles of review, looking at what we were doing, using quality improvement methodology, and then to be able to get data that would really explain what it is that we were trying to achieve with a team to a wider audience. So that pathway kind of explains the number of people who were involved, actually, who I tried to involve as much as I could in creating the team to make it sustainable. Next slide, please. So the work streams, are acute management, support of patients with acute exacerbation and admission avoidance. And then the routine work stream, which centres around improving and empowering patients to self-manage in a way that keeps them out of hospital, that helps them to understand their disease, that optimizes their management and encourages things like smoking cessation. And next slide, please. And so, I was asked to speak a bit about challenges. So obviously data is a challenge for everybody. The evolving of this was me in the beginning, just gathering bits of data, qualitative data from patients and questionnaires, and then, having support from a project manager for boxy reporting, and then engaging with data analysts and people who know an awful lot more about developing clever things than me. But it was about that kind of clinician analyst relationship of me saying, look, I'd like this to be able to demonstrate that. Next slide, please. And so we came up with the Tableau method that we can pull lots of interesting service statistics quite easily. And this is only a slight example of what we can pull. And beginning to think about, what is the impact of our service and what is the, saving in terms of bed days. Next slide, please. So as well as looking at Tableau and things, we started to look at other sources of data. So Public Health Scotland between 2019, halfway down that graph, up to 2021, shows an increasing population in Midlothian of COPD patients, and a sort of 50% reduction in bed days amongst and admissions relating to that time, which was a time where we expanded the team, but also a bit of caveat around COVID. And we want to keep having a look at this Public Health Scotland data to see what the admissions are doing and understanding that. Next slide, please. And again, this is quite a long, goes back quite a number of years, 2004, where we see in every 100,000 population, you have 350 admissions. And then a downward trend over time with this work going on in respiratory and primary care, keeping patients out of hospital, and now down to 190 admissions per 100,000 and Midlothian sitting underneath the Scottish national average for admissions. So it's important to have a look and see, where can we get other sources of data around hospitalisation. Next slide, please. Another just a bit of population information that we're getting from Tableau. Again, just one of a number of different tables and slides that we can get. The left-hand column showing us the population of COPD patients admitting into hospital, and the color coding, the orange not known to CRT and the blue known to CRT. So this left-hand column, we see KIs on it, obviously, but that can help us with some case finding work and inviting these patients to have the CRT service. Middle column is about patients who are frequently admitting. And we see also in those columns other comorbidity information. So the top two there can be, cancer and COPD related, or heart failure and COPD related. So it does give us some clinical information there as well. And the right-hand column in Tableau gives us the current admitting patients, so we can reach in and we can facilitate those discharges home. So it's just it's a bit of a glimpse of what you can do with data to help develop and quality improve your service. Next slide, please. And, another challenge, obviously, for us, staffing. I think we'd all like to be the little Lego guy in the right-hand column, producing staff out of the hat, but that's not something that happens. We've had to work hard at this. We've had to, improve and motivate respiratory knowledge in a larger team. We've had various ways of trying to get patients, staff interested, so secondments in, fixed term contracts, and then trying to get onto permanent funding. So I think this is something that we, throughout Scotland and probably wider, struggle a bit with anyway. But it's trying to have some quality improvement, some data behind that to really be able to push and show what the benefit is, which I think is the thing that hinges. Have a think about as well the biopsychosocial approach. So the effect of breathlessness on these patients makes them anxious, drives hospital admission, the impact of mental health. How do we as physios tackle that repeated hospital admission because of anxiety? It's very, very difficult. So that's where we found the psychology intervention so helpful, that this is the thing that really helps to impact. Next slide, please. Again, just a little bit more around, trying to introduce 5 rotation students, thinking about your workforce skill set. Who is it that in primary care can do this work? How does that look? How can we do more of it? And then setting up the team, thinking about who are the experts in your area. Laura Groom, who'd set up Edinburgh CRT, was massively helpful for me setting up. And the support of Gaurab Chowdhury, who's the respiratory consultant, with that kind of aim over wider picture, really important. Next slide, please. We get feedback from a lot of different places. The key, there's a bit of work on the website, so the Midlothian Partnership website, which collates a lot of qualitative information from patients on various people into themes. And, just to highlight, support the middle bit, supported patients with treatment at home. These patients do not all need to be in hospital. They just need teams to reassure them and support them at home. And the top right comment, really important, keeping mum at home out of hospital as much as possible so she can enjoy quality of life at home in her last days. Palliative disease, we should be looking at where we can treat these patients the best. Next slide, please. And that's just the conclusion. So thinking about what support can we develop, what can we, what effect are CRTs and other work in the community having, keeping care at home for patients and using data to help us develop these services. And it's going to get more difficult caring for patients with lots of complex comorbidities at home. We really need to push for these specialties to be happening in the community as well. Thank you very much for listening and welcome your questions.
Oh, just Scott's maybe busy typing.
No, here I am. No, that was great. And Claire, your camera's not working for some reason. So everyone, that was Claire.
Sorry, you can see me. Sorry about that.
Well done, well done. Well, amazing. And Anne, it's great to see you. And do you want to kick us straight off with Sing to Breathe? Surely everybody's interests are now piqued. So we're looking forward to hearing from you now.
Okay, thank you. Is my camera on? Can you see me okay?
It is, yeah.
Good,
absolutely.
because I'm not going to use any slides. You're just going to see my face, which is probably not a good thing anyway. But so my name is Anne Ritchie, and I co-founded the Chain Gang in 2013 with two general practice nurse colleagues, Pauline Waugh and Sarah Marshall. I'm now retired, thank God. But we were at that point somewhat frustrated by the lack of accessible rehabilitation. This was 10 years ago, and pulmonary rehab was available, but the waiting times were long and it wasn't as accessible as it is nowadays. And also patients didn't really like the idea of pulmonary rehab. I'm not sure if they still do, if they do anymore or not. And this was despite us encouraging them enthusiastically. But we were all interested in singing, and we all sang in choirs, and we knew how good it felt when you sang with other people. We felt great after it. So we found some research from the Sydney DeHaan Centre in Canterbury that proved the physical, mental and social health benefits of singing for people with long-term respiratory disease. And they reported improvements in debilitating breathlessness, reduced anxiety, in better sleep, reduced social isolation. And this just persuaded us really to go ahead and do something with it. So we secured some funding from the Queen's Nursing Institute of Scotland, and we enrolled 8 patients. And we employed a singing coach. She's American and she's hilariously funny and just a bit off the wall. And we met for 2 hours every second Monday, I beg your pardon, in Chain Street in Stockbridge. And one of our members coined our name because our meeting place, and also because he felt all his peers were shackled by the same condition, that is COPD. And incidentally, many years later, we discovered that Chain Street, in fact, was named after Dr. John Chain of Cheyne-Stokes breathing fame, who was a physician in the 1800s and had an interest in respiratory medicine. So using a truncated version of the St George's Respiratory Questionnaire called the AQ20, which is 20 questions with yes/no answers, and the more yes answers, the worse your quality of life is. We started a 6-month singing period. So we did the AQ20 at the beginning and we did it at the end. And we were able to demonstrate a significant improvement in quality of life, but also because the patients were from the practice where Pauline was a practice nurse, we were able to look at their records. And we discovered a reduction in antibiotic use and a reduction in hospital admissions. And this was all the more remarkable because it was done between October and March, when we would expect to see an increase in exacerbations at that time of the year. We also gathered some qualitative data by employing an impartial person to conduct interviews with the 8 patients, which just galvanised the findings of the original work that had been done in Canterbury. So to cut a long story short, we gained charitable status, and now we have 4 groups in Edinburgh, 1 in Glasgow and 1 in the Scottish borders. Our aim is actually world domination, but I think in the absence of that, we would be quite happy to just see groups set up all over Scotland. And with that in mind, we've just partnered with Chest, Heart, Stroke Scotland, and we're currently running a training course for singing group leaders and any interested healthcare professionals. And it's running at the moment, and we've got 20 people on this course. And we're hoping at the end of that these people will be able to set up groups across Scotland, and will be supported by Chest, Heart, Stroke Scotland to do that. If we can get enough people, enough groups across Scotland, then we would have a perfect cohort, I think, for a clinical trial on the benefits of singing for lung health, because I think that's where we need to go next. I would like to see singing for lung health placed in beside pulmonary rehabilitation. And incidentally, our drop-off rates are much lower than the pulmonary rehabilitation drop-off rates. Some of our members have been with us for 8 years, for quite a long time. This year we did some work with our health at the University of Edinburgh with the engineering students. This is just a wee aside because I really was excited by it. Who went into partnership on a research piece with our members, and engineering students we're talking here, not medical students, and they had to do reflective work, and it was completely out with their comfort zone. It was quite interesting to watch. But one example that they came up with, they were looking for practical solutions to the problems that our members face, was to look at the gradient of the streets and the pollution levels in Stockbridge. And so what they did was they came up with an ergonomically designed bench, and as well as street signs that indicated the gradient on a sort of traffic light system, and also that particular day's air pollution. We're now hatching plans to work with occupational therapy master students from Queen Margaret University as well. At the tail end of the pandemic, we started getting inquiries from people with breathlessness associated with long COVID. And at that point, we were looking to see what was available and realised that actually there wasn't a huge amount available. And there wasn't really joined up care for people with long COVID. And so we decided to produce a website, and we decided to go with bite-sized videos about various problems associated with long COVID. We used a respiratory physio, we used yoga instructors, occupational health nurses, all sorts of people from across the divide, and of course a singing teacher. We got money from the Sir Tom Farmer Foundation to set it up, and it's still available. It's called www.longcovidsupportscotland.com. So, I hear you say, get to the point, Anne. How does singing help alleviate breathlessness? So most of the people we work with, some 180 people now, are living with COPD, bronchiectasis, asthma, and we aim to encourage the use of singing and the breathing techniques that we use to help gain control of the breath. So we teach our members to breathe by engaging the abdominal or core muscles, and to keep the accessory clavicular muscles as still as possible. Using the accessory muscles of the neck and the shoulders and the clavicle results in high, inefficient breathing that actually uses up a huge amount of energy. So low belly breathing is what we suggest, and it also benefits our members whose breathing difficulties stem from other sources such as long COVID, heart failure, and anxiety. And I think it was Claire was talking about anxiety, and singing definitely helps with anxiety. So we choose songs that help to extend the out-breath, thereby tackling breathlessness that is associated with the hyperinflation and air trapping. And then an example of this, I'm going to sing to you now, an example of this is a simple counting song that incrementally extends our out-breath. I'll demonstrate for you now, and I'm just so sorry I can't see all your faces because I would have had you all singing it. You can try if you like, you can join in. So we start with 1. 1, 1, 2, 1. 1, 2, 3, 2, 1. 1, 2, 3, 4, 3, 2, 1. 1, 2, 3, 4, 5, 4, 3, 2, 1. 1, 2, 3, 4, 5, 6, 5, 4, 3, 2, 1. And we go up to 8. Now, you can imagine that by the time they've done that, they're so busy trying to count because they're having to go backwards that they don't actually realise that they've sung for 16 beats without taking a breath, or without noticing their breath, actually. I think that's more like it, without noticing their breath, and they're extending their out-breath nicely. And they're able to do that because we've taught them to breathe from the belly. One of my favourite exercises, breathing and singing exercises, is called puffy or hamster cheeks. And it's one we try to include in every session because it's actually essentially breathing through pursed lips, but you're singing while you do it. And you know, people with COPD particularly will often breathe through pursed lips and almost as if they're whistling, you know. But we actually also try to include this particular exercise when we're demonstrating or singing or performing in places such as the Scottish Parliament. And there's something very strangely satisfying about watching a bunch of parliamentarians singing Happy Birthday through puffy cheeks. It was very, very amusing for me anyway. I'm going to sing it, I'm going to demonstrate it here. Puffy cheeks is like this, and you have a little hole here in your lips where the sound comes out. So you go And what's happening there is that you're controlling the amount of breath that you're taking. You're extending the out breath because the phrases get longer as that song goes on. But it is wonderful to watch people trying to do it. So in addition to being fun, singing is a whole body experience, and even the most reticent of our members find themselves swinging or tapping their feet, or they're definitely moving their body in some way. And with this in mind, we try to incorporate movement into songs. We try to include 7 things in each session. Breath work, obviously, which I've just discussed with you. Singing, we choose the best songs for the situation, either quiet or loud or happy or not so happy, and songs with short and long phrases to help extend the out breath. Movement, where possible, we have people to stand as if they can when they're singing. We do physical warm-ups at each session, and obviously we make it clear to people that they should only do what they're able to do. Group work, we try to be as inclusive as possible and encourage friendships. We have fun. We do relaxation. There's always time for relaxation. And cognition, we try to sing songs without lyrics sheets where possible, and we sing in different languages. And our members self-refer. So if they need to refer themselves, they can do that by getting in touch with me through the website, which is www.thechaingang.com.
And that was fantastic. I mean, I think it's. I mean, I still don't. We have not had a singing presentation yet on this webinar. 13 webinars in 2 or 3 years we've been going, and I've still not had a singer. And you look at those love hearts and claps going around the table there. So such an amazing, inspirational bit. And no less, you've kept it really focused to improving their respiratory health, but the benefits more widely with regards to social inclusion and cohesion and working together when you've got, illnesses which aren't always curable in the traditional sense, and to help support them to maximize their healthcare is really good. And it's great. Helen, are we going to put off people that are tone deaf? I'm sure this is an inclusive group where tonality and musicianship are not always the first barrier joining, and I'm sure it's a very inclusive group, isn't it?
Yeah,
would that be correct in saying so?
No
additions required.
And
look at that.
If you can talk, you can sing.
And rurality as well is they're being discussed by Claire, thinking maybe about maybe online versions of it and things like that. If people are really far out and they can't do it in that, but a great and inspirational talk there, Anne, and I'm sure stimulating some of our colleagues' ideas. 211 people on the call. I'm no doubt that other things might be done in this ilk, even if the evidence is not overwhelmingly strong according to Cochrane, although Cochrane are looking at it with serious eyes to see if they can unpick what evidence they can find for it. It's certainly really chiming well with social inclusivity, and good community spirits, and that's really great to hear. Guys, I'm just going to wrap up there for the day. It's been so amazing to hear about the work that we have in our communities to working towards this winter, where respiratory illness is a massive burden for us leading into winter. It's definitely great work that I know my colleagues have been doing across the country, both at national level from Alpina and the team, but right down to those our consultant colleagues in the hospital supporting us, also down to those community respiratory teams that work within the practices to support respiratory health, with our practice nurses, of course, as well as the specialist nurses in the communities, and then right at that kind of third sector support there with these great innovations that Anne highlighted today. So it's amazing to hear all this great work. It definitely starts off a little bit doom and gloom, but look at that. There's lots of things that we can be doing in this area to improve the quality of care. Thank you so much. And I'm just going to hand over to Adeline for the closing words. Thanks everyone for attending today.
Thank you, everybody. It was a really, really interesting webinar for me, and I hope it was the same for you. It leads me to say thank you to everybody who has contributed to today's session. Shout out to RCGP, Scottish Government, and NES, with whom we produced a series of webinars. And thank you to my fabulous organizing team, Katrina, who is on leave today, Christopher and Melissa. We have all put in so much effort to pull these webinars off. You're going to see a poll that's going to pop up in front of you now. Thank you for everybody who's participating in this. And it's a survey to tell us how we've done in the webinar and to give us some feedback around how we can improve this webinar series. The recording and slides that are used in the webinar will be uploaded to our website, and once we've done that, we'll circulate that to everybody who registered. Please do keep in touch with us by any forms of communication on this slide if you have any queries or any suggestions. We have now come to the end of our webinar. Thank you again and enjoy the rest of your day.
Take care, everyone. Well done.